Well, folks, I have to tell you that today I feel like a kid in a candy store because I am really honored to have an amazing physician, researcher, and a human being on today's podcast. And you know that somebody is very famous when is referred to by one word, which is Govindan. So the Govindan, although he will introduce himself with his full name in a little bit, but I'm really pleased to have Govindan today's podcast. I think you're going to enjoy it a lot because we're going to talk about just all things lung cancer and go through the journey of how lung cancer care and therapy has changed over the past 2 decades. Govindan, welcome to the Healthcare Unfiltered podcast. It's really an honor for me to have you. And I'm humbled that you're taking an hour of your time to be with me. So first of all, maybe a little bit of introduction about you and who you are, where you work, how you spend your day. But also, as you introduce yourself, maybe take us what got you interested in thoracic oncology. I presume most of us who've done fellowship in oncology, we go into fellowship with not a whole lot of decision what subspecialty we are going to do, and then something happens. So take us through that.
Good. First of all, thank you so much for having me. You know, I've been a big follower of yours, and I watched the podcast with great interest. And it's an honor for me to be on this podcast, Charlie. Thank you so much. You know, my story is a very typical immigrant story. You know, I came to this country in 1991 with 2 suitcases and $18. And, you know, I say that not to brag about myself, but it really shows what this country is all about. You know, I didn't know anybody. And those were the days when we got telephone interviews, and I came here, you know, with $20, and I spent a couple of dollars in Los Angeles airport. So when I got off the plane in Chicago, I had $18 and some change. A friend of mine picked me up, and the hospital, Michael Reese, no longer there anymore now, on Lakeshore Drive, gave us a bunch of immigrants at the time in that class of ours. So the secretary there, I remember her name very well, Kim. She was really kind, arranged for $1,000 loan. So there was a check of $1,000 waiting for me. So overnight, I became very rich from $18 to $1,000. And then I cashed it and got the apartment deposit. And then they took $100 every month of our paycheck. So it was not a free gift, but it was still a loan, and it was a very timely loan, and it really helped. And that's how I began my career in Michael Reese, a residency there. And then I came to Chicago. I came to St. Louis for my fellowship. And then I was on J1 visa, which is a visa that, you know, you have to go back to the home country or you have to serve in underserved areas. And after fellowship, I spent 2 years at Cook County Hospital in Chicago in the ambulatory care clinic. I did only half a day of oncology. You know, rest of the time I did internal medicine. That was a requirement for the visa. And 2 years later, I came back to WashU. I tried multiple places and nobody responded, or people were busy with other things. And I didn't get any job after my 2 years of that visa commitment. But fortunately, WashU took me back, and then I began my career. Ever since, I've been here and I've never left. I came back to WashU in 1998 as a faculty. John DiPersio, my current boss, a remarkable man. I was his second recruit, and either he saw some promise in me or he was desperate, one or the other. But the good thing is, I like to think of former, but you know, he gave me a nice opportunity and has been a great source of inspiration for me and guided me all throughout. You met him when you came here, and truly a remarkable physician scientist and a great leader. And I've been here since then.
And Govindan, what got you interested in thoracic oncology? Did you always want to do thoracic, or were you shaped by someone else? How did that happen?
You know, my mentor when I was a fellow at Washington University was a remarkable man by name Dan Idy. And some of the, you know, older generation physicians would recognize him. He was the deputy director of the National Cancer Institute, and he was recruited to Washington University midway through my fellowship. to head the newly formed cancer center here. Unfortunately, Dan got into health problems, but Dan was described by many, including Paul Bunn and John Minner, as a man with encyclopedic memory and remarkable position and a clinical investigator. And poor Dan was having some health issues, very soon after he arrived here. But he was very kind to me, and it was quite inspirational. In fact, my very first paper on lung cancer was written with him in Small Cell Lung Cancer Review in one of the Hematology Oncology clinics of North America. Dan was, in a way, inspiring. Was an inspirational figure at that time, even though he was not at the top of his game. And then after I came back to WashU, Dan's health declined even more. So they asked me to pick up his practice, and that's how lung cancer became my passion over time. And it was a bit of a mentoring from Dan early on, and then the vacancy left by his departure. So I took over his patients and took over his practice, and that's how I began practicing lung cancer.
But when you did your fellowship, it wasn't you were not sure yet whether you're going to do general oncology or any particular type. You did your fellowship, you went to do primary care and some oncology. At that time, you were still not certain if you're going to specialize or not.
I knew one thing. I wanted to stay academic, and in academic medicine, I wanted to do clinical research in oncology. Lung cancer was certainly on the list, but wasn't finalized. I didn't really embark on it until an opportunity arose. So, like many things in life, things just happen. It was not like I was dreaming of becoming a lung cancer doctor. There was a simple explanation. Nothing much was happening in lung cancer then. We had one chemotherapy regimen, and lung cancer was not as prominent area of, people were flocking to breast cancer, and bone marrow transplant was a big thing then. And lymphoma was moving along. Herceptin was just coming along at the time. So those were very different days, and lung cancer was not the in thing at that time. But I was mainly concerned about getting a job as an immigrant and as somebody on visa. That was a big challenge for us. So I was consumed by that. And I was going through some personal challenges at the time in my family. So we were anxious to get a job, not only for me and for my wife. And that consumed most of my energy and passion. But then once I came back and I started practicing lung cancer, then it became truly a natural fit. And things started happening one after another at that time.
And later on in the show, I'm going to ask you a little bit about the education, mentorship, and how the culture of academia has evolved over the past 3 decades. But let's try. I want to, first of all, the first half of the show, I want to take the listener through advances in lung cancer, really what has happened, because it's fascinating for somebody who is not a thoracic oncologist, and seeing what's happening, it's really fascinating. So let's start with the first 5 to 6 years when you were a thoracic oncologist. My first question is, did somebody tell you that you're crazy for doing thoracic oncology because it's like a dead field? And number 2 is, how was taking care of patients with thoracic malignancies in the late 90s?
Great, terrific questions. In fact, as a matter of fact, my former chairman of medicine in Cook County said, he liked me very much. He said, Govindan, are you going to do lung cancer? What is that for? He said. And I smiled, and he was not sure why I made the decision. People were doing breast cancer at the time, as I said, lymphoma, transplantation, lung cancer, of all things. And that I remember him making the remark. He was an extremely wonderful guy, and he wasn't saying it to put me down. And he was truly, that reflected the state of the field at the time, so to speak. And the interesting question is, how was it like? This may interest some of our younger audience members here. I'll tell you what happened. The state of care, or in 1998, 1999, when I was practicing lung cancer, stage 4 non-small cell lung cancer, the commonly used regimen at that time was platinum etoposide. And paclitaxel was coming in. That was a new thing. And carboplatin, there was a big debate. Every conference, you'll have the debate, cis versus carboplatin. You would agonize over that. Stage 3, chemoradiation was a new thing. The so-called Dillman study, where this was a famous study led by Bob Dillman for CLGB, then called CLGB, now called Alliance, and where patients were randomized with stage 3 lung cancer to radiation or chemotherapy followed by radiation, that showed for the first time some improvement in outcomes and survival, overall survival. And then whole set of questions were asked, concurrent versus sequential. But those were the days when radiation alone would be fine. Chemo followed by radiation was just coming in for stage 3. And stage 1 to 2 lung cancer, even 3 lung cancers, if they can operate, there was no role for adjuvant therapy at the time. In small cell, we did chemoradiation like today with platinum etoposide. That's a sad state of affairs. We still do the same thing. And with now immune checkpoint inhibitors in extensive stage small cell lung cancer, etoposide platinum was the standard thing. Topotecan was just coming in experimental setting for relapsed small cell. That was it. PET scan was just coming in. 1 or 2 places were using PET scans. It wasn't the routine thing. CT head was the standard. MRI of the brain was in the standard thing. Forget about sequencing, molecular analysis, none of that stuff. We just got cytology, non-small cell lung cancer, and off we went.
It was pretty interesting. I took the first internal medicine boards in '98, and the 2 take-home messages were always, we were warned that make sure you always answer no if they ask you about adjuvant therapy for lung cancer. Make sure you answer no if anything pertaining to screening for lung cancer.
Right.
And I think also the third most common question, I still remember there were particular clinical parameters that if you see, you definitely offer hospice and you do not offer chemotherapy. I think I remember maybe like hypercalcemia, performance status, weight loss. And if you have these, definitely right. Hospice, do not choose chemotherapy. There's like, the cheat sheets of lung cancer. But it's rather interesting. So, and for the younger generation, like you're saying, they may not appreciate that because they probably never saw this. It's funny you mentioned the carbo versus cis, because I promise you that there were some careers in thoracic oncology literally made based on how many editorials were written differentiating cis versus carbo. JCO had always like something every 3 months.
Yeah. In fact, people may know this Cosmides trial, and Dr. Cosmides from Greece did the study comparing cis etoposide versus carbo etoposide for small cell. And that's still, I think, the best study looking at this head-to-head. But there's always been a big debate. And every conference will have this discussion. There'll be passionate advocates on both sides. And also remember, those are the days when the academia had not caught up on the chemo and the chemo-related, the support, revenue, etc. And the chair time was not the in thing at the time. And now then it became much more of a major issue, how much time somebody occupies in a chemotherapy chair. And the differences were marginal between cisplatin and carboplatin. So I think that debate is settled now for most part.
So what happened? And what was the rate limiting step? What happened that, like, you always think, something happened that started changing how we approach lung cancer. When did this happen? Take us through the history, if you just whatever happened.
Yeah. One of the great advantages is you've lived through some of that, right? So you really can, I remember those distinct moments. I think the biggest thing happened was, in my opinion, the introduction of gefitinib. If you really think about if you go back in time, of course, you can pick different points and say, this is the most important moment. For me, I think gefitinib was a pivotal moment in lung cancer systemic therapy. I remember sitting in one of those rooms with a bunch of our colleagues from lung cancer world, and we were discussing launching a trial with this drug, an oral drug, and gefitinib, an EGFR tyrosine kinase inhibitor, and at that time called Resa. And I remember somebody making a comment, and how do you expect a pill to help these patients? They're very sick. And in fact, that time, mind you, we did not know anything about the EGFR mutation.
So what made them, why, like, what was so special about Irissa that somebody said, let's study it in lung cancer?
I think the EGFR was obviously a known target. EGFR, the head and neck and lung were thought to be important. While we didn't know that the activating mutations were driving these cancers, this drug targeted EGFR, so there was a lot of interest. And before that, the EGFR itself has been recognized as an important, player in cancer, at least in head and neck and lung cancer. And so at that time, there was some skepticism, I have to say, that a pill could help these patients who are so sick. We thought very much like some lay public, how can a pill help such a devastating disease? And then a number of studies early results were quite striking. And there was some unique thing that came up that some patients responded very dramatically. And we were trying to figure out, is it related to hormonal status? And I think Vince Miller and others from Memorial pointed out very nicely that the smoking status has something to do with that. So even though we have been seeing the non-smokers with lung cancer, we didn't really pay much attention to this entire new discipline or a subset of lung cancer, non-smokers with lung cancer. And I think Vince Miller's paper was probably the first one, if I'm not mistaken, really identifying the non-smokers and the response to gefitinib. And then we really have shown. Then later on, many of us have had patients. I remember the second patient I took care of, who was on the gefitinib trial. She was in a compassionate program. By then, we had begun to see some activity enough to have compassionate programs, and so the requirements were less stringent. And so this patient had signed up for hospice care, came to check on, is there any option available, and was very sick when I saw her. And we put her on gefitinib. A month later, I couldn't recognize her. And she had become, she's one of those Lazarus stories. And she lived for 3 years, and then had a cardiac event that really caused her death. But those are the days when we began to see these dramatic responses, and then the recognition of the EGFR mutation, done at Boston MGH as well as Broad. And then also working with Harold Warmas, our group here, the building just behind me, where the sequencing was done that led to recognition of the mutations, including the T790M right here in St. Louis, in collaboration with the group in MSK and Harold Warmas and Vince Miller and William Powell. That really opened up, our recognition that the activating mutations played a major role in this disease, and then that led to erlotinib, adjuvant studies, etc.
I'll have to say, I mean, is it fair to say, and I don't want to put words in your mouth, is it fair to say that the initial signal that maybe there's something special about Irissa or gefitinib and so on was based on subset analyses where people just went back and said, right, let's see who's responding, and they found women, non-smokers, Asians, and so on?
Yeah, absolutely. The famous story often repeated is when a story of, the story ran in Boston Globe of Tom Lynch's patient, and then later on read by the people at MGH, and that led to the studies and identification of the EGFR mutation, the simultaneous work at Broad, and with Bruce Johnson and Matthew Mercer and Pasiani. And so all these dramatic stories that came out in, I think, 2004, and that really nailed this cause for these dramatic responses. So here, you're right, empiric therapy, observation that some patients did well, and access to samples, and using the appropriate technology at that time, even though we didn't have the current next-gen sequencing so widely prevalent then, really opened up that field. And it's truly is, in my opinion, a milestone in systemic therapy of lung cancer.
And the way the EGFR receptor was discovered, like you said, Vince Miller and your group and several other groups, there was a decision made, let's try to sequence lung cancer tissues. And
yeah. I think the first, I think I would say the credit goes to the group in Boston, Tom Lynch, Matthew Marson, independently, these two groups recognized the responders, and then they went back and sequenced those tumors. And then Harold Warmus, who was then the cancer center director and the president of Memorial, working with Mark Chris, Vince Miller, sent the samples to St. Louis, and we sequenced some of those samples. I wasn't involved in that directly, and our genome sequencing center was involved in that, and they confirmed the mutations described by the Boston groups a few months earlier, and then identified the gatekeeper mutation. And then not only we identified the mechanisms of response to EGFR TKI and TKIs at that time, but also the acquired resistance as well, the T790M, the gefitinib.
So then the gefitinib was discovered and the erlotinib, and then I recall vaguely gefitinib was withdrawn from the market or something, and then erlotinib stayed. And then take us through that phase where we started seeing the EGFR mutation was identified, and then somehow gefitinib lost favor, erlotinib came in, and then something happened also. Things took off after that. I would say let's go through the period between 2000 and 2010.
Yeah, I think the gefitinib, it's still an active drug. In fact, recently I had a patient who just came off, has been on gefitinib for over 14 years. And, again, it's a single patient. Gefitinib is an active drug widely used in the rest of the world. It's only in the US, it is not used, it lost approval earlier on. And now the reason was that I think poorly designed study. There was a study called ICEL that didn't meet the primary endpoint. And it was not mutation specific trial. It was just all comers. And then later on we became, and the erlotinib trials were designed, I think, much more, learning from the experiences from the gefitinib trial. And there's a little bit of luck too. But then later on trials focused on the mutant group, the osimertinib studies were done focusing on the EGFR mutant patients. So we became much more sophisticated in our trial design with increasing knowledge. And I think the gefitinib loss in the approval, this was one of the early drugs that got an accelerated approval, to the best of my knowledge, and then lost it because the lack of positive results in the confirmatory studies. But we probably would be designing those studies differently today, And if you had done those things, gefitinib would have probably done okay.
But then we started having so many of these EGFR inhibitors. Like I honestly don't know how many we have out there. You do, but do we have a lot? Isn't too many?
Not particularly. We have some. Of course you have the gefitinib, erlotinib, and then afatinib. And afatinib was this the middle child. And then osimertinib really is a mutant-specific one. It less toxicity. It's shown to be superior to other drugs. So that has become the norm today. It's used now. And essentially, I think it comes down to, in most of the world, it comes to osimertinib, if they can afford it, or if not, gefitinib or variations of that. And in some situations, afatinib is still used, especially those with the compound mutations. So it's basically, I think it's come down to a couple of EGFR inhibitors around the world right now. EGFR TK inhibitors, I should say.
Yeah, it is. How do you find that it's difficult choice in terms of selecting the EGFR inhibitors, or is it now like if I bring 10 thoracic oncologists and it's first line therapy, do they all say the same? Do they all select the same drug?
Yes, I think they'll all say osimertinib. I think that debate is over in the US. In other parts of the world, cost is a problem. Even here, cost is a problem. I'm sure you're going to have you may have already had many podcasts on this. In many parts of the world, there are no insurance system, no state payer, and the gefitinib is much cheaper, and so people still use it. But in the US, I think I cannot think of a good reason. The common mutations we're talking about, exon 19 deletion and L858R, I would say osimertinib is their go-to drug.
And then how did you guys discover the ALK mutation, and then you started developing drugs against the ALK? How did that happen?
So the ALK was an interesting story. This came from the paper from a group in Japan, and it was not done through a conventional next-gen sequencing, describing all these targets, and it was done through a very old-fashioned method. And it so happened that the cell line they were working on had ALK rearrangement, and also serendipitously, crizotinib was being developed as a MET inhibitor. And in a phase 1 trial, a patient who had an extraordinary response turned out to have ALK rearrangement. And then that led to crizotinib studies. And then once you realize that the ALK is indeed prevalent in 3 to 4% of non-small cell lung cancer, obviously the pharma got very interested, and the ALK much more selective inhibitors were developed. And then that led to now quite a few in that space. You have crizotinib, alectinib, lorlatinib, brigatinib. And so we really have a number of those drugs as well now in the ALK positive group.
So the ALK, basically the original study was developed as a MET inhibitor.
Crizotinib was initially thought to be a MET inhibitor, and I think just happened to have a patient with a nice response, had to have ALK rearrangement, and that's the story I hear. And I think I've heard this many times. So,
and then how do you select? We talked about the EGFR. It seems like at least I would say 90% of the thoracic oncology community is agreeable. How about the ALK inhibition in terms of first line?
I think what is clear now is the alectinib and lorlatinib have greater penetration in the brain, and they are superior drugs compared to crizotinib. So I think for all practical purposes today, I think most people use, at least I use alectinib, and some I think use lorlatinib in the frontline setting. So it's been narrowed down to those drugs, especially if they can afford it. If for some reason people cannot handle alectinib or lorlatinib, crizotinib, I guess, is an option, or brigatinib. But I think in most of us, outside of a clinical trial, most of us use alectinib, I think, for ALK-positive lung cancer in the frontline setting.
And if somebody has EGFR, they cannot have ALK, right? They're completely mutually exclusive.
Typically. And occasionally we have seen patients. In fact, right now I have a patient who has EGFR mutation upon progression found to have ALK rearrangement and responding nicely to alectinib. And so it does happen, but they are very rare, not very common.
So is it fair to say that the decade 2000 to 2010 was the decade of ALK inhibition and EGFR inhibition?
I think it's very fair to say that. Those are the time, the stories, the dominating reports or papers coming out focused on EGFR or ALK at that time in lung cancer, especially in systemic therapy. Around the same time, a few other things happened too. Right, we established the adjuvant therapy as a standard of care. A series of studies established that there was a modest but clear improvement in overall survival with the use of adjuvant chemotherapy. That is a big deal in my view, because we began to cure more patients. Not just controlling the cancers as in metastatic disease. In stage 1 to 3, we were curing more patients, 5 to 10%, with the use of adjuvant chemotherapy. And also, I think around the same time, I think the concurrent chemoradiation was seen to be the standard of care in stage 3 lung cancer. So I think that also happened around the same time. So several things were going on at the time. And so all of them led to an improvement in overall survival, in my view.
And then maybe the adjuvant studies for EGFR mutant tumors or ALK positive tumors, were they starting to be developed or not yet?
Right. You really know your timeline extremely well. You've done your homework beautifully. Here is the thing, that the adjuvant trials were beginning to be thought of. It's a natural outgrowth, if you can imagine. When you see chemotherapy improves overall survival, you want to ask a question: could the adjuvant, EGFR inhibitors maybe of help? We did have a bit of a bad news on that front. We designed a study where patients got adjuvant gefitinib after chemoradiation, and it turned out that the adjuvant chemoradiation worsened the outcomes compared to those who did not get adjuvant gefitinib following chemoradiation in stage 3 lung cancer. This was a SWOG study. And without going into the details of that, but we continued our efforts to optimize EGFR TK inhibitors in the adjuvant space. And we began this effort called Alchemist in the US National Cancer supported trial network sites, and where we screened a large numbers of patients. Right now, we've screened over 7,000 patients, early stage lung cancer. If they have EGFR mutation, then they got adjuvant erlotinib or observation. If they had ALK rearrangement, then they got adjuvant crizotinib or observation. And then the others went on to get immunotherapy following chemotherapy, that's nivolumab in this case. And we also are using all those samples to do comprehensive genomic analysis. So those studies were designed or conceived around the late 2000, end of 2009, 10, and then they became more operationalized a couple of years later.
So when did this fiasco over PD-1 and PD-L1 then start? When did we, when did this take off and start?
Yeah, before that, one other thing happened, Charlie, if you can go back and ask this. And around 2008, I would say that, as you know, the human genome sequencing was completed around the waning days of Bill Clinton's presidency. It was announced in the White House with Tony Blair and Bill Clinton about the successful completion of the Human Genome Project, both by the private as well as by the public enterprise. And then 4 or 5 years later, we published the very first comprehensive whole genome sequencing in a cancer patient using acute myeloid leukemia. Tim Lay and Rick Wilson from Washington University published this comprehensive analysis. It was only 13 years ago, but think about this. One whole genome sequencing got a Nature paper, just one whole genome sequencing. There was a big effort at that time, and it was thought to be a very difficult thing to do. Cost-wise, when I give talks, I highlight this. The Human Genome Project was done in 4 centers, MIT and Broad, Washington University, Baylor and Houston, and at Sanger Institute in the UK and other institutions. But these are the 4 major institutions that led the bulk of the work. It took 10 plus years, the public enterprise, and $3 billion BS and boy. And when we did the AML sequencing, whole genome sequencing, it took us about a year and a half and $1.5 million to complete this. So the cost has come down. I always point out that this was 2 genomes, not 1, because at that time, this patient's leukemia was also sequenced along with the skin sample as well. So there's 2 human genomes. So the cost was really like $700,000 per genome. And that is a far cry from $3 billion, literally 8-9 years earlier. And so then around the same time, the Cancer Genome Atlas project was launched. And the goal was to sequence over 10,000 tumor samples from over 33 tumor types, including lung cancer, about 1,000 of them. And Steve Balin from Hopkins, Matthew Meyerson from MIT, and I led the project. And we sequenced at the end of the day about 1,000 lung cancer tumor samples and published 4 papers, 2012 in Nature. First, we defined the landscape in squamous cell. Then we did this in adenocarcinoma in 2014. And those are the 2 first comprehensive papers outlining the genomic alterations using whole exome and whole transcriptome. And then we updated those things later on in Nature Genetics in 2016, and more recently, early this year in Cancer Cell Reports. And so that really opened up, additional targets and gave us some idea of what the genome sequencing taught us about the lung cancer. And around the same time, the immunotherapy was coming in. And so the 2010 to 2020, helped us clarify more about the genomic alterations in cancer. And we spent a lot of time defining that.
And what was discovering the PD-1 and PD-L1s as potential targets something that basically came out of the genome, or no? This was
No, it was unrelated to that. And I think the main thing was the Bristol BMS worked with Medirax, and they had this PD-1 inhibitor that became later on known as nivolumab. And there was a lot of interest. And we had reported in 2012 that the smoker lung adenocarcinoma had 10 times more mutations than the non-smoker lung adenocarcinoma. But even before that, it was widely anticipated that melanoma and lung cancer may respond well to immunotherapy. And those studies were launched. Of course, melanoma was a few years earlier than us. And then the lung cancer early results looked compelling. Again, phase 2 data, phase 1, phase 2, fantastic results on some patients, 15 to 20%. So one thing led to another. Then Merck came along with pembrolizumab, and nice studies were done. And then the PD-L1 inhibition was thought to be better and safer. And then we have those drugs like tocilizumab, durvalumab that came along. And so all these studies with global participation redefined the field. And tempted by the EGFR story, people were trying to really find a biomarker that could really nail down who are those patients who respond very well to immunotherapy. And I would say that work is still work in progress. We have not really, we've got some answers, but we have really not solved that problem.
So scientifically, just a couple of questions that came to mind. Scientifically, do you feel that there's that may be a stupid question, but hey, it's okay.
There are no stupid questions.
Scientifically, do you feel there's a difference if you inhibit the PD-L1 versus the PD-1? Like, do you feel, is there any difference? Like, I don't know.
There was a thought, and I'm no immunologist either. So, there was a thought at that time that the PD-L1 inhibition may be safer rather than the PD-1 inhibition. And I don't see a big difference between PD-L1 and PD-1 inhibition, at least we haven't compared head to head. But I think, when we see the side effect profile, response, efficacy, I don't really see a big difference. And, the standard of care has evolved over time.
And how do these interact with the EGFR and the ALK? In other words, if you have EGFR mutation, are you expected to have low PD-1, like, is there any, or completely irrelevant? You can find it all.
Yeah, Charlie, this is a kind of a modern day version of cisplatin versus carboplatin debate. And, how do you use PD-1, PD-L1, PD-1 versus PD-L1, PD-L1 as a biomarker? I'll tell you, maybe my views are biased. The way I interpret the data, here are the following comments I would make. One, the PD-L1, high level of PD-L1 expression in the tumor cells identify a group of patients who would respond well to single agent, checkpoint blockade. And the best data we have is from the pembrolizumab data. And, the studies, the Keynote 24 and 42 studies have taught us that. And I think high level of expression, PD-L1 50% or more, identifies a subgroup of patients who respond well to single agent immunotherapy. When I say immunotherapy, I mean PD-1, PD-L1 directed inhibitors, particularly pembrolizumab. And I use in my practice, if you have a high level of PD-L1 in the tumor cells, 50% or more, I would consider pembrolizumab single agent for those patients, especially if they don't have large, bulky volume of disease. And if they have large, bulky volume of disease, then you want some chemotherapy to go along with pembrolizumab in order to have a, earlier cytoreduction, because the action of pembrolizumab takes a little while. On the other hand, in a large group of patients, 1 to 49%, I think these patients are better off, in my view, by using the triplet therapy in the non-small cell lung cancer and in the space. If a small cell, we don't really use PD-L1 expression. And one of the curious things about small cell lung cancer, if you have time, we can talk about that later, is that here is a tumor that is seen almost exclusively in smokers, high mutation burden. Still, the response to immune checkpoint inhibitors is quite impressive, modest. And in fact, nivolumab did not even meet the primary endpoint against topotecan. And in small cell lung cancer in the relapse setting, So we still have to understand the reasons behind that. But putting that aside, the PD-L1 expression helps us identify a group of patients who would benefit from single agent checkpoint inhibitor, in my view. That's where I use it the most.
So we've gone through from mid 90s until 2020 in terms of the evolution from chemotherapy, targeted therapy, sequencing, all of these things. Where are you, where's the thoracic oncology field heading over the next 10 years? If you're designing project plan, what do you want to see in the next decade in terms of research?
Yeah, it's a great question, Chari. So, we were in the space where 10 years ago, we were unable to sequence, the tumors in a expeditious fashion, and it took us a long time to do it. Now we can do it faster, we can do it better. We can even go down at a single cell. Now, as you may have seen, many of those single cell sequencing papers where we can look at a few thousand cells, identify this great heterogeneity in the tumor samples by doing the single cell sequencing. Now we can really do proteomics. Until recently, we could only do a few proteins. Now, in fact, we published 2 papers not long ago, one in Cell in 2020 and one recently, again in Cell. The first one was on adenocarcinoma. The latest one is on squamous cell cancer, part of the NCI CP-TAC effort, and where we sequenced over 100 tumors comprehensively, over 10,000 proteins and about 40,000 post-translational events in each of them. So we can really find a lot of these alterations that are not picked up at the genomic level. SHP2, for example, is not the protein is, you can see the phosphorylation of this SHP2 protein at a very critical site, but we don't find gene mutations in this. So what happens at the protein level and the post-translational modification may be quite important. And the new generation studies will help us identify the proteogenomic alterations, and we can interpret that beyond the DNA sequencing. Also, I think we will be looking at the immune landscape much more closely and better using the single cell sequencing, and we can identify the subpopulations of macrophages, immune cells, and with great clarity. And I think in the next 10 years, we will be able to identify those things. The challenge is to get good quality samples asking key clinical questions. The days of describing what we find in 100 adenocarcinomas, 200 squamous cell carcinomas, those days are over. They are not interesting questions anymore. But we have to really tie that to therapeutic questions. Why do these patients, you have 2 sets of patients, one getting a PD-L1 inhibitor responding very well, the other one getting the same inhibitor responding poorly. What is defining the genomic and immune landscape? And using these technologies, we'll be able to get an answer better, and maybe we'll be able to validate them and go after them therapeutically later on.
So there are 2 camps out there. One camp says that histology matters in cancer, but there's a growing camp of investigators. Some of them are senior investigators, others are junior and more motivated, that says, you know what, histology does not matter. If you have adenocarcinoma of the lung that is driven by this oncogene, and it's the same oncogene that's driving the breast cancer in the other person, I don't really care of where the cancer started from or the histology. Which camp are you in? Do you think we're jumping ahead of ourselves by saying histology does not matter?
Unlike religion and politics, it's better to have an open mind, in science, right? So you go where the evidence is. And, for example, I think it is probably a wrong focus in my view, and I could be wrong. So obviously, I don't want to be too dogmatic about it. But what we have come to appreciate is a great example is KRAS G12C, right? So we have a great drug. We have now good drugs for it. I won't say great drugs. We have good drugs for it. And we see some activity, and very encouraging, something that we didn't think we could target 4 years ago, 5 years ago. It's a real tribute to medicinal chemistry more than biology or anything. And I have been involved in the KRAS G12C inhibitor development with sotorasib, and we've seen dramatic responses in the setting of lung cancer, lung adenocarcinoma. not so much in colon cancer, adenocarcinoma of the colon. So I don't think we have reached the point where we can have KRAS clinics, EGFR clinics. People talked about that, when you and I were doing fellowship times. So eventually, that's how we would all be practicing cancer, or a little later than that, fellowship times. But I think what we are missing is the context matters. The KRAS G12C mutation lung cancer occurs with concurrent alterations of certain, types. And whereas the same in colorectal cancer may be influenced by other alterations. We have learned one thing, that the cancers don't start overnight, right? They have a long gestational time. And now with all the wonderful technologies we have, we can identify the founder clones. We have identified the key mutations that initiated the process and the concurrent alterations at the the subclonal level that have evolved over time. And they, along with the tissue of origin, resident, macrophages or the immune system, they sculpt the tumor as they evolve, and they have a certain say in the matter. And that's why I don't think we are ready to ditch the histology or even the site of origin at the moment. We may reach a point 10, 15 years from now or earlier with a better set of analysis, better artificial intelligence tools, putting the data coming out of this proteogenomic analysis, and then may give a certain predictive approach to certain drugs and targets. Then the histology may not matter so much. But we are not there yet. But I think eventually we may get there, but we are not there yet.
I know I've taken a lot of time, but it's just so much fun to talk to you, and I'm sure you have a lot of things to talk about, but to jump to. But I want to take the last few minutes, just learn from you. You've been doing this since fellowship, training, and faculty, close to 2+ decades. How have you seen, one, the academic culture have changed over the past 2+ decades, and education and mentoring? It's an important part of every academic physician. And we have to admit it has changed a little bit, because me and you, before we went on the show, we were talking about, I honestly used to read the entire paper. I actually used to enjoy reading the paper, although I wasn't actually interested in the field, but I loved reading the discussion, and I was learning how to write papers. But now you could barely read a tweet and you make a decision based on a tweet or an abstract or a title. So as an educator, as a mentor, as an academic, take me through the change in academic culture. And have you morphed the way you teach and train and mentor junior faculty?
No, Acharya, I think you're right about this. Now it's challenging. It's very hard now because the field is tough. There's more competition. Those were the days when 8, 10 of us would gather every year at Martha's Vineyard and decide the lung cancer program for 2 or 3, design 2 or 3 major trials. And those days are gone now. And justifiably, in my opinion, it's more democratized. So, but I think the key principles are the same. You have to put your head down, work harder, come up with a single good question, follow with good clinical trials, work with your colleagues, and then take one step forward. It's a long slog. You cannot get answers quickly. There are lots of challenges. You have to write 10 proposals to get one approved. You should not lose your heart. It's easy to say that. Currently, a couple of my grants are being reviewed today, so I've been checking the scores as that happens. So you have to really, when you don't get a good score or when it gets table, it does hurt your feelings.
You're checking your grant score. I'm checking the Red Sox scores. I don't know what's going on there.
So, but I think you have to enjoy what you do. What the job you and I do is a privileged one. And we take care of patients who go through really indescribable suffering, and we are happy to play a part in making this better. And I think the research has come a long way, and now we can really find a good mentor, a good place, and really enjoy what you do, and not look for short-term benefits, and just really give yourself 100%. At the same time, you got to enjoy, have a balanced life. And that's the only way to longevity in your career. It cannot all be about work or about you. And it's just a long-term process.
Oh, that was really great, Govindan. Any last thoughts? I mean, I have so many questions I would love to ask you. I just want to be very respectful of your time, but I want to make sure that we cover everything pertaining to the journey of lung cancer. I think the listeners have an appreciation of what you've gone through in terms of research and therapeutics. It's hard to cover everything with lung cancer. We did not, for example, focus on the adjuvant setting and on the early stage. We did not talk about advances in surgical techniques, radiotherapy techniques, because we both are medical oncologists. Um, but anything else you feel that folks who are listening, they really ought to know and take to heart?
No, first of all, I want to commend you and congratulate you on the great work you're doing. And I think really it's very helpful, quite inspirational for me to listen to your podcast and listen to the history of medicine in many ways. And I think people have to take time to go back and look at the histories to have an appreciation of what you have. You know, when you think about we complain about Epic and all the electronic health records. I think that's certainly understandable. But then we also forget the time when we had to go down to the film library, request a person, pull the hard films, put them side by side, and suddenly one important sheet is missing because somebody had walked away with that. So compared to that, now you can sit there, you can be a continent away, and you can look at the films and call a patient from there. So the technology has enabled us to do a lot more things. At the same time, it is occupying more and more of our time. So we got to really have a handle on that, but I appreciate where we have come. You know, this conversation has energized me, to be honest with you, and looking back and see where we have been 15, 20 years ago, how far we have come. We still have a long way to go. So we got to be careful about doubting our own progress is too much. We still lose patients. A lot of our patients are dying earlier than they should. We don't give them a full high quality of life, a great quality of life. We still have a lot of work to do. So we got to be a little bit more humble about the progress, the need for more progress, and appreciate, how far we've come. At the same time, work very hard.
Well, I very much appreciate it. I think sometimes the one thing that looking at the history that triggers in me individually as a person, as a human being, is the patients that we lost before these advances were there.
Right.
You know, I mean, I think there is no question. I mean, I know for sure I've lost some relatives and some patients that they probably had the EGFR mutation, right? And you just look back, it is what it is. It's all about timing.
Right.
There's nothing really you could do about this, but that's why we need to have an open mind. And I would say, and maybe I'm a little bit more pragmatic than the hardcore academic physicians, but I do feel we have made a lot of advances in oncology, in medicine, because we did not necessarily always stick to the fact that you must do randomized controlled trials. Like sometimes you can actually do a subset analysis, you find something and you follow that. You can think a little bit differently. If we always stuck to the gold standard, we'd probably still be where we were. Maybe, I don't know.
Yeah, but we have to have rigorous studies, but the nature of studies vary quite a bit depending on the situation. But I think, the subset analysis are very useful, but they need to be prospectively validated.
Yeah.
And they are hypothesis generating, and anecdotal cases are useful to illustrate a point as long as it's followed up scientifically and validated. So I think you have to keep those old principles still in mind.
Well, we need to have you back, though. We need to have you back.
I'll be honored to, Chadi. I'll be honored to. 10 years from now, we'll do it again.
Oh, no, not 10 years. Come on. No, but this was really wonderful. I look forward to sharing this with a lot of folks and a lot of, I think a lot of lung cancer physicians would love to hear this and just hear your views. There are physicians that right now taking care of patients that would laugh at us if we thought carbo versus cis. Like, what?
Right.
Somebody actually did a JCO paper about this?
Yeah, I know. Do you remember the famous, everybody was looking forward to Joan Schiller's presentation on the ECOG study comparing
ECOG 1494. It's,
Yeah, and, the 4 different regimens, they were all hugging each other.
Yeah.
What Larry Einhorn would say, failed the laser pointer test because you cannot put the laser pointer between the curves. We have come a long way since then. We still have a long way to go.
Well, it's wonderful to talk to you. Thank you so much for your time, and I look forward to seeing you very soon, hopefully in person.
Thank you, Chadi. Thank you very much. Wonderful.